Hello and welcome to the Royal College of Pathologists CQI Awareness Month webinar series. My name is Maya Laxdal, and I'm excited to be hosting these sessions where we have leading experts guide us through key CQI methodologies and skills for making change and improving patient care and safety. I'm pleased to introduce today's speaker, Dr. Martin Goddard. Dr. Martin Goddard is a consultant histopathologist at Royal Papworth Hospital. He is a clinical lead for cardiac pathology, including cardiac transplantation. Dr. Goddard is also the subspecialty advisor for cardiac pathology at the Royal College of Pathologists. So without any further ado, I'd like to kick things off by welcoming Dr. Martin Goddard. Martin, over to you.
One of the key things in order to make change and improvement is the use of data. Data underpins all improvements that need to be made. And often we find when trying to get improvements made that people have no idea about what they do, how they do it, and where they want to get to. So data is a key thing in allowing us to know what we want to do and how we want to change it. You can't see any change without measuring it. So in order to demonstrate that you have moved from point A to point B, you have to have a metric at the end of that that shows the improvement that you have made. And if you're going to change the way people do things and the way changes are made, then you need to get everybody on board with you. You can't push people into change. It doesn't work. It's trying to push people through a small doorway, but you can pull them through and they will come and follow you. So it is a key for us to understand what we mean by the term data. Data is that background accumulated information that is available that allows us to inform our planning and our decision making. And in pathology terms, we often think of that data purely as how much activity we're doing, rather than thinking about the quality of what we're doing and the benefit that the patients achieve by us actually undertaking that work. In terms of metrics, these are measures. These have to be put in place to monitor outcomes. And any project will have to have clearly defined metrics which will underpin and demonstrate that you have achieved what you are aiming to achieve. So data is the evidence that underpins any change that we want to make. It allows us to look at the steady state that we are in, and it will actually give us information about where changes can be made. When you can question your data and interpret it and understand it, then you can identify the changes you want to make, and these will lead to improvements that can be made. Furthermore, your data systems have to be capable of producing metrics. And this shouldn't be just auditable data, i.e. going back retrospectively over a period of months to look at what data you've accumulated again. That does not really help to drive through a change improvement program. Metrics need to be those measures that you can measure in real time. That is to say that you can give a week-by-week report on activity or whatever your outcome measure is to your people to show that they are delivering the change and sustaining the change throughout the process. We know, and it's often said about the NHS, that it's a data-rich organisation but intelligence poor. And whilst we have got better as an NHS overall in using our data, we are still not very good at it when you compare us to industry. Computerization of the NHS has continued apace, and probably many institutions are now at the stages of using electronic patient records as a way of improving the quality of their patient care. But pathology services were, in most institutions, the first clinical hospital services to computerize. And we have been collating data and using it for getting on for 35 years now. And there's a vast resource of data that is available within pathology departments to understand what is going on in the clinical world. The level of information and how it can be interrogated will vary depending on the systems used within a different hospital. But more and more of them can look not just at activity, but also on positive outcome results. So you can look at what your percentage positive rate is for any test within any clinical setting. However, in thinking about the projects you want to do and the data you want to use, you should not confine yourself simply to using the pathology data sets that you own. There are many other areas of the hospital activity that will be available to you as other data sources. In most instances, the finance systems have been computerized for many years, and these have been done to allow the organization to better understand how their business is running, what it is truly costing them, and for that they need to understand what the activity is, even down to the level of individual patient testing. And this becomes a very valuable resource to mine to provide further data. We often find that data sets within pathology systems are incomplete. Tests are sent without the referring consultant's name, but we still do them and the result goes back because we can send it to a clinical ward. But when you're starting to interrogate your data, the richness of all that information becomes increasingly important. But these additional holes in the data can be found in other data systems, and therefore you can have a complete set of data to look at. Hospitals on the whole tend to use two different types of systems, although it may vary from institution to institution. Many have set up what are called service line reporting systems, which are there to provide data to business units or their equivalents within the hospital that look at the activity, and they can take uploads from pathology systems, but they can look at what is being done in individual units and measure activity in that way. Other systems include patient-level costing systems, which allow you to drill data down to the level of an individual patient. And you can take the activity level for patients at individual tests. And these can be subdivided according to different categories, be it consultant or clinical group or diagnosis, and allows you to look at those clinical behaviours that are being applied. It is important, wherever possible, to collect as much data from multiple sources as possible before embarking on your improvement project. Triangulated data is more robust and less easy to challenge. Clinicians, particularly where you are challenging certain aspects of their clinical behavior, will always find reasons why the data is unreliable and not applicable. So the more robust the data you have, the more likely you are to get engagement with them. You won't get the pushbacks to them. There will always be the excuse that it wasn't their patient, but usually every patient has an identifiable consultant for a clinical episode, so we can get around that. They can argue on individual patients that they're an exception, but when you start to look at groups of patients or cohorts of patients under different settings, then we start to see important trends in the way in which pathology resources are used that we can then use to say, how do we improve the service? In healthcare, certainly within the USA, and probably to a slightly lesser extent within the NHS, it's estimated that as much as 20% of healthcare spending is wasteful, i.e. we're doing things we don't need to do or shouldn't be doing and generating waste in the system. By using the data we collect from our information systems, we can actually remove some of that waste. We can look at the consistency of clinical practice. We can look at standardization, that is to say, within a patient group undergoing an identical or similar procedure, is there a standard of practice that's being followed that gets the achieved outcome? We can also use the data to acquire new knowledge, which is to say, what do we learn from doing this? Is it a benefit to the patients? If not, should we not be doing it? And the resources that's saved, or the additional of testing, or the reallocation of testing, will allow us to deliver more effective patient care. So having collected your data and begun to analyze it, the idea for an improvement that needs to be made will fall out of that data usually. But it is important to have a clear idea about what the improvement is that you want to make. What is the outcome you wish to achieve? What are the benefits that the organization and the department and even patients are going to see by making this improvement? If we consider looking at demand management as one area where we can improve quality of care, we may be looking just to reduce the overall test volumes and reduce the wasteful testing that's going on. It may be that we need to tackle increased activity, which is becoming unmanageable within a resource-stretched laboratory service where it's difficult to either recruit staff or get additional funding to support this. Are there ways of removing repetitious tests or unnecessary tests that are being done? Can we change the processes that allow us to use the testing capacity that we have in a more efficient way? And do we look at variability of clinical practice? That is to say, do all clinicians in similar situations behave in the same way? Is there a standard to which they should be achieving? And all of these questions and ways of thinking about what you want to do will fall out of the data that you can collect. Understanding and analyzing the data is important, and you may need to get the help of special data analysts to learn how to use the information. Excel spreadsheets are particularly useful in analyzing data, as it allows you to pivot the data around different points to look for different patterns and activity within the data you collect. And therefore you can look at the data in any way and select it out for different parameters, whether that be based on activity, looking for variability in practice, or looking at benefits of clinical practice. All of these aspects will drive the project and decide what needs to be done and what you want to do. And at the end of the day, once you know what it is you want to do, that will actually determine what your outcome metrics are going to be. What is it you're going to measure to demonstrate that you have achieved the improvement that you wish to make? And once you have identified those improvements, you can quantify the benefits that are going to be made to the benefit of the organization and to the service. Virtually every pathology department will have seen activity increasing at a faster rate than clinical activity overall within the hospital. Often if you're on a fixed budget, this becomes very difficult to manage. Now, increased pathology testing may in fact be the right way forward for managing patients. Increased testing and pathology tests can be a good use of resources. They can lead to better clinical decision making, leading to better outcomes and reduced length of stay. Whilst a cost to the laboratory service overall for the organisation, they show considerable benefit, and for the patient it is also a benefit. But there are other drivers to increase pathology activity that can occur. We see, certainly in some laboratories or in some organisations, there's more defensive practice. People are doing more tests because they feel they ought to, not because they need to. We also have seen certainly that introductions of electronic requesting systems rather than the use of paper-based requesting systems causes an increase in demand. It is very easy to click a button on a screen. It's very laborious to handwrite out the form. We've also seen changes in pathology activity because of protocol changes. Many patients are managed on protocols, but these are not always regularly reviewed or updated and may not reflect continuing best practice. Variability in practice is an area which is only beginning to be recognized within healthcare. It's been widely understood within industry for many years, and when they look at their systems and think of systems thinking, variability is described by them as the root of all evil. If you have a standardized process, it should not vary, or should only vary within certain parameters. Variance outside of those parameters are indicative of something not being done in an appropriate way. And we can see that within testing requests within organizations, that in certain conditions, certain individuals with the same cohort of patients will have a different set of testing repertoire undertaken. Now, they may be exhibiting best practice and we need to bring everybody up to the level, but often they are being overzealous in their testing, and we need to actually relook at how they are performing and what they need to do to take those tests out. This allows benchmarking not only between consultants within your own units, but also you can compare departments and benchmark across centres within comparable centres within the country who do similar types of activity to look and see whether they are following the same sorts of protocols. Possibly the most challenging things to change which impact on activity through the pathology laboratories is clinical behaviours. It's about understanding why clinical colleagues are requesting certain tests in certain ways and what they wish to achieve from that. And in order to be able to challenge those clinical behaviours, the importance of data is that it provides us with the evidence that we need to say, why are you doing this? Is this the appropriate thing to do that? We can look at the protocols that they have in place and audit against those protocols to say, you've agreed those protocols, are you following them? If not, why not? Is the protocol wrong? Does it need to be changed? Or do we need to change the behaviours and get people to perform against the protocol? And all those things can be used and dictate outcome measures. either by reviewing the current practice or looking at their activity. It is, however, often quite difficult for those of us in the laboratory specialties to challenge clinical decision making or clinical behaviours. The ripostes I have suffered include I'm not having someone in the laboratory telling me which tests I can order. And I'm not trying to tell them what to do. I'm trying to understand what they want to do and allow them to use the resource in a more efficient way. Often laboratory tests are perceived to be cheap, and on an individual cost basis, many of them are, compared to the cost-based decision making that many clinicians have to do on a day-to-day basis. But it is the sheer volume of tests that are undertaken within hospitals that mean that making changes is a very worthwhile from the financial aspect. The threat to do patient harm by making changes is one that will always be waved at you. It is the classic shroud waving response to any change that is often felt from clinicians. The important thing is to listen. Their concerns are legitimate, and if you are going to achieve your goal, those discussions have got to take place before you introduce the project, and they have got to be addressed in a meaningful way that gives them confidence in the changes that you want to make will not be detrimental. Often we are accused of not understanding what the purpose of the test is. And sometimes they may be doing tests that are no longer appropriate because they themselves, as clinicians, have not kept up to date with what new tests are available that may be more appropriate. So often even advice on appropriate testing may be something that comes out of the discussions that are had. Often we see patients being monitored on long-term care by having routine blood tests done on a regular basis. But is the frequency appropriate? And are they going to make any changes in their decision based on the results that they have? And all of these are legitimate questions to pose to them. It is about challenging what they do in a way that just asks them a simple question, and if that is the best way and they can justify it, then that is fine. But if we do not review all these processes on a regular basis, then we allow bad practice to just continue to accumulate. The outcome of your data and clinical engagement should be to define your objective. And the objective should be as clear and defined as you can possibly make it. And if you have a good, clear objective, you will define the metrics you need to measure to demonstrate that you have achieved your objective. You should be clear about what you're trying to do with this. Is this about removal of waste and unnecessary tests? Is that the primary driver behind that? Is that the measure? Is it reduction of costs? And reduction of costs in the pathology services can be quite difficult to realize. What is more likely to happen is that you are freeing up the resource of the laboratory to allow the laboratory to undertake other types of activity rather than actually going to generate a huge cost saving. More and more, the driver for change within the NHS appears to be a need to reduce costs. And we would be naive in thinking that there is not a cost pressure within the system that we all have to be able to address. However, costs alone should not be the primary driver. Patient outcomes should be the patient driver. And if you improve patient outcomes and you send them home from hospitals sooner with less complications, you will reduce your costs and improve the patient outcome. On the level of the pathology services, often the clinicians have no idea about the cost of individual tests. They are perceived as being cheap, and yes, they often are. But some of them can become really quite expensive to do. The use of electronic requesting systems has allowed us to put in the cost of a test within the software, so clinicians can see how much they are spending when they're doing so. But the finance director will then say, well, we can save that if we don't do the test. But often, in terms of what we can achieve in terms of benefits of costing through reduction in activity, is only the marginal cost. That is to say, what is the cost of reagents for doing a test? Because we're not going to be able to shed staff and we're not going to be able to get rid of the equipment. It is only if you outsource your pathology services to a third-party provider, is it likely that you'll be able to recover the full cost per test when you reduce activity. So In terms of the benefits that you can achieve, it is important not to overestimate what you think the cash releasing benefits are likely to be. So I will now talk about a single case study that we undertook, just to reiterate and to go through the points that I've raised in the introduction that you've already heard. It's a small and simple improvement that was made, but it illustrates the points that have been made. Many years ago, as with many centres, we adopted the Matching Michigan program, which is the way of reducing line-associated infections in critical care units. As part of that process that we set up at that time, central line tips on removal were routinely sent for culture to the microbiology lab in large numbers. This is quite a costly exercise to do and was perceived as being of little clinical value. So clearly we were seeking to change a clinical behaviour, change the way in which the patients were being managed in the critical care unit. For this we needed evidence. So we used the data that we had to provide the evidence that we would need to make the change. So we looked at the total number of line tips that we were being asked to evaluate, that were being sent for culture, and we looked at their positive culture rates as a percentage, but also had a figure for the total number of positives that were undertaken. In fact, the positive rate was extremely low, below 1%. So 99% of the testing was very reassuring, but didn't really add any benefit other than reassurance. So we had to look at a protocol to say which lines should be sent to maximize the value, and then how were we going to measure this and what was it going to tell us. So the stakeholder engagement was undertaken through an audit of the positives in the first instance. We were looking for clinical parameters that would define those patients who were more likely to have a positive culture result. And we were able to identify, through looking at the positive group and as a matched group of negative cultures, the patients with persisting pyrexia, with a white count that was rising or a rising CRP, were usually those who had positives, and those parameters were not seen, or very, very rarely seen, in those patients negative. Also, to alleviate the concerns of the clinicians, we were quite happy to accept that they would send the tips where they had clinical concern, without being any more specific about what that meant. Allowing them to request against their clinical concern was important so that we were not perceived to be trying to undermine their ability to make clinical decisions. Having defined our indications for the test, we agreed the metrics that we would do, which is to look at the activity, i.e. the number of tips sent. We had a historical norm, so we knew what our baseline was going to be from our data, but we could also audit against the number of central lines inserted overall on the unit if we needed to. It was important to measure the percentage positive rate, but also the absolute number of positives. As the number of line tips was going to go down and the number of positives was likely to remain the same, the headline percentage positive rate was going to go up, but the absolute number should stay the same. Again, in response to their clinical concerns, we agreed that we would monitor to look for any unexpected bacteremias that occurred within 48 hours of any line change or removal that occurred. And this was to be our sort of safety net to demonstrate that we have not caused any patient harm. So our outcomes were very good. We were able to demonstrate a 75% reduction in the number of line tips sent for culture. We, of course, had an increase in the percentage positive rate, but that was proportionate to the reduction in the number of line tips sent. So when we looked at the absolute number of positives per line used, there was no change. And we found no evidence of an increase in later bacteremias following removal of the line, again demonstrating that we had not achieved or caused any harm to the patients. This demonstrates the importance of having clearly defined outcome metrics and clearly defined objectives for your project. You will not see change without metrics because you cannot measure them. Your initial data, again, allows you to know where you are. It allows you to set out and define the change you're going to make, and then it allows you to identify the metrics, which will be how you measure the change. And having those metrics easily measured that you can continue to measure is important to embed the new practices within the organization and allowing for sustained improvement. Sometimes in defining your objectives and the metrics you're going to measure, there'll be a core metric that you want to do. In this example, this is about the activity. We want to reduce the amount of activity. That's our objective and hence our core metric. It can, however, be also important to have a number of secondary measures that are considered in your metrics. Many hospital quality improvement programs require that all projects undergo a quality impact assessment before initiation. And this is an independent review by clinicians to look and to say, have we considered fully the possible impact on patients and ensure that there'll be no patient harm. In this case, that measure was the measurement of bacteremias to ensure that we hadn't inadvertently led to patients having more septic episodes. In this case, we were able to clearly demonstrate that we had had no adverse events. Sustaining change can be one of the most difficult things to do in any organization. It is the natural behavior of people to revert to the behaviors they know best, which is to go back to doing what they did before in most cases. So whilst the project is ongoing and the metrics are being reviewed, those behaviors remain good because those metrics are clearly visible. But if at the end of that period measurement stops, there is a tendency to revert back to previous behaviors. And there have been many studies done on this, both in industry and in healthcare, that demonstrate that it can take 12 to 24 months to embed new practices and behaviors within organizations. The way to make change sustainable is to continue the measures. Now, therefore, the measures need to be simple, easy to produce, without creating a whole body of work in itself. But by continually producing those metrics and making sure that people achieve those targets, over the period of time, they will become self-sustaining. So it is important to identify metrics that you can continue to do and easily measure. And you need to have a way of presenting your data to the people involved in those changes that is simple and easy to understand. They do not want to be searching through reams of paper to find where the measures are. And very much modern practice is the utility or the utilization of clinical dashboards, simple graphical representations of those metrics which are presented, be it on a weekly or monthly basis, on a real-time basis to those clinical areas. Feeding back the information through these dashboards and continually monitoring embeds the change, but it also reinforces the message to the stakeholders about the process you have gone through. One is that you can make change that does not harm patients, that benefits the organization, and that you can keep it sustained, and that they've been listened to and that they are part of that process. This is not something that has been done to them, it has been a project that has been done with them. So one of the outcomes that we have to think about is the benefits. What benefits have we realized through making these changes? The obvious one in the example given is that we've reduced the amount of testing that is being done. That reduces the burden on the laboratory. It has notionally reduced the cost of that. But it's also improvements in lots of other areas within that. And part of the secondary benefits that you can see when you make these changes are benefits more widely in the organization. So this goes to the point that if somebody is taking the line tip, they don't have to request a test. It doesn't have to be packaged. It doesn't have to be transported across to the laboratory. We don't have to do all those other processes. If we're reducing those things, there's less overproduction. You can reduce motion. You can reduce inventory. You don't have to carry so much stock or material around, and you're not transporting useless samples around the organization. These are all secondary benefits that can be difficult to quantify, but are part of the benefits that the organization will gain through the changes that you can make. So what have we learned from undertaking these processes? Importantly, that even in laboratory services, we can change clinical practice if we provide them with the evidence and the data that underpins that to allow those changes to occur. So we shouldn't be shy of engaging with the clinicians to alter their clinical behaviours and requesting patterns. But the methodologies that we use must be clearly evidence-driven. It must demonstrate why we want to make the change, what is important about that change, and we must listen to the clinicians to make sure that they understand what we want to achieve, but also what their concerns are and how we're going to address those concerns in doing that. It also highlights the importance of simple, defined outcome metrics that can be easily measured and presented in a way that is clear and understandable for all parties. The metrics must be continued over a period of time beyond the completion of the project to ensure sustainability. Through many cycles of change processes that we have been involved in, it is quite clear that you need to start with a small, defined project and gain a positive outcome. It is all too easy to try and do a big project, and it is all too easy to fail a big project. The clinicians will gain from working with you on the small project, have confidence in what you want to achieve, and will even start to come back to say, can you access the data that tells us what we're doing in X, Y, or Z so that we can make further improvements with you on this?
Thank you to Dr. Goddard for this interesting presentation, and thank you for watching. For more information on everything that's happening during CQI Awareness Month, go to rcpath.org/CQIaware. Remember to tune in on Thursday, the 23rd of May, for our podcast with Dr. Tom Lewis, where he discusses innovative approaches to change and the importance of approaching improvement from the patient perspective. This webinar was developed by the Clinical Effectiveness Department of the Royal College of Pathologists. This webinar was hosted by Maya Laxdal, recorded by Kate Stewart, and directed by Maria Marrero-Feo. Thank you for watching.